Well, I think we'll get started. I think there's probably waiting 1 minute for people online to join in. But just to get started, my name is John Wagner. For those of you that don't know me, I'm the program director or leader for the Transplant and Cell Therapy program at the Masonic Cancer Center. And it's my pleasure to introduce Nick Zorko, who is an assistant professor in the Department of Medicine. And he's tackled a problem that in prostate cancer and other genitourinary tract solid tumors, looking at the use of various antibody therapies. But in addition, he's also going to introduce you to the concept of autologous transplant, really the first cell therapy that's been proven to be successful in many lymphohematopoietic types of cancers, but now thinking about it in the context of solid tumors, but also then moving from there to the use of immunotherapies, including potentially in the future, cell therapies. So, I think what you're going to be talking about is some of your work with bi and tri-specific engagers in the context of solid tumors. But, he has got a provocative title, I guess, thinking about our heritage here and looking at what happened, in the context of transplant like in 1999, which is interesting because I was first thinking about, what does Nick know about 1999?
We'll see in the second slide.
For those of us that did transplants, and as Dougie would remember, the most common solid tumor for which we did autologous transplants was breast cancer. And it was huge relative to this. All solid tumors are represented probably about 50 to 60% of all the transplants that we performed with autologous transplants. Needless to say, that's no longer the case, although some would argue that maybe we prematurely discontinued it, but that's the rare population of investigators. But nonetheless, I think the future is going to be in the context of immunotherapies for a variety of cancers. So Nick, we look forward to your presentation and thank you for joining us today.
Thanks for the introduction and thanks for inviting me here today. So as you can see from the title, don't transplant like it's 1999. Solid tumor engagers take the lead in 2024. A little bit of a change to the title, but I think it fits overall with the theme here. So for the overview, we'll talk very briefly about high-dose chemotherapy for solid tumors back almost 25 years ago. We'll talk about new developments for solid tumor immune engagers, and particularly the evidence that's recently come out supporting their feasibility, especially with two of the newer generation molecules. We'll then talk about natural killer cell infiltration into solid tumors and why we think that natural killer cells may be the next way to go to move therapeutics forward. We'll talk about B7H3 as an ideal solid tumor target, development of our dual camelid B7H3 trike and the preclinical side, and then finally some future directions too. So let's take a step back to 1999. Things have clearly changed. As you can see, I'm highlighted in the purple there. I had a whole lot more hair. It was a lot longer, and it was blonde. This was, I think, January 2020. So I had just turned 16, and I got my driver's license and was a sophomore in high school. I had no clue that you could do a bone marrow transplant. I didn't even think I was going to be an oncologist or an immunologist. So let's put that in perspective of what's changed in 25 years, and I'll highlight a little bit about what's changed in the practice for the treatment of solid tumors. So in 1999, this review came out talking about autologous stem cell transplant for solid tumors in adults. And like Dr. Wagner mentioned, this was quite a thing back then. I don't have much knowledge about this. I know it more from historically and it being referenced, but very little of the data behind it. But really what I wanted to do was use this to highlight again the changes that have happened in practice here. And the general concept from my understanding, having not ever done this before except for germ cell tumors, was really the goal was to escalate the chemotherapy dose beyond what the bone marrow could tolerate. So once you give marrow toxic levels of chemotherapy, blood counts would not recover. So we would really follow this with an autologous stem cell infusion, also known as stem cell rescue. This, from my understanding, was pioneered at Indiana, maybe have been others as well, but particularly for the germ cell and testicular cancer regimens that Larry Einhorn developed that became curative for an otherwise incurable cancer. And really, the other term you can call this is high-dose chemotherapy with stem cell rescue. And it makes more sense, but it also takes a lot more explanation when you're talking with a patient as opposed to just saying autologous stem cell transplant. There was early evidence that it could have been, it was effective in breast cancer, small cell lung cancer, ovarian, and some other solid tumors, but it faded relatively quickly. And when I talk to my patients about this even now for germ cell tumors, I really refer to this as the sledgehammer approach, because we are really escalating our doses of chemotherapy significantly. When I talk to my germ cell patients, the doses of carboplatin that we use, everybody ends up with hearing aids at the end because we use so much chemotherapy for it. So keeping that in mind, practice has evolved in many ways for this. High-dose chemotherapy with stem cell rescue remains an option for testicular cancers, and we do those reasonably frequently here at the University of Minnesota, one every 2 or 3 months lately. But they're otherwise not commonly used anymore. The only other indication we actually discovered was later for small cell ovarian cancer hypercalcemic type, which we did our first transplant in the last year for. Otherwise, therapies have improved really rapidly, and right about that time is when monoclonal antibodies were first approved. So rituximab, trastuzumab, antibody drug conjugates have been developed, novel combination chemotherapy regimens. Looking back at some of the references from that time, I don't recognize most of them as a recently certified solid tumor oncologist. And then hematologic malignancy has really led the way for immune effector therapies, whether it's CAR T with the multiple products approved for lymphoid malignancies and multiple myeloma, but also bispecific antibodies in that space too, targeting CD19 and then BCMA in the multiple myeloma space. The problem in the solid tumor world is that immune effector therapies have lagged for solid tumors. They've been ineffective or extremely toxic, or both in that case. Particularly in prostate cancer, we have limited immune therapy approvals in any space, but really it's the metastatic castration-resistant setting. So patients that have progressed with a castrate level of testosterone, which is typically the baseline of therapy for all prostate cancers. As you can see highlighted from from NCCN guidelines, which is basically our guidebook for treating cancers, there are 2 therapies that they're highlighted in blue. One is Sipuleucel T, which was approved in 2011. I've used it once, and most of the other general urology oncologists don't use it for the most part. At the University of Minnesota, we think there are other options that are probably as good or better, and also less expensive in that case. The only other immune therapy that is approved for prostate cancer is pembrolizumab, so anti-PD-L1 antibody, and this only applies to about 3% of patients. So these patients have to have microsatellite instability, mismatch repair defects, or tumor mutational burden of greater than 10 mutations per megabase or more. So it's a very, very rare subset that we're able to apply anything immune related in the prostate cancer space. So there's clearly room to grow in immune therapies and with that. So taking a look at some of the changes really in the last year, or really even 6 months in the prostate cancer space, xaluritamig, which I've just learned to finally pronounce here, had really great results from a phase 1 trial here. So this is a STEAP1 CD3 immune engager that's been produced by Amgen. And you can see the figure on the right with the design for AMG 509, which is the other name for this. So it has 2 STEAP1 targeting FABs, a CD3 targeting scFv, and then a silent Fc, basically to increase the molecular weight and also prolong the half-life. I'm not going to spend a lot of time talking about this, but really the point with this and the next drug that I mentioned is that there is now a strong signal and good potential to show that immune engagers have efficacy in potentially a variety of solid tumors. So maybe we finally overcome that hurdle that we've been working on for years to try to redirect T cells and treat late-stage cancers in this case. So with AMG 509, one of the important things is this is a very heavily pretreated populations. Patients treated on this trial for metastatic castration-resistant prostate cancer had 4 or 5 lines of prior therapy, with the median of 4 lines of therapy. So this is not an early stage trial. These are patients that have really experienced and progressed on pretty much everything we have to offer in the CRPC space. Cytokine release syndrome was the most common event, as highlighted by the red box here. So we can see there was quite a few grade 1, probably 30%, but also a significant amount of grade 2 and not infrequent grade 3. It was rare, but grade 3 in my mind is really the step where you really start to see significant toxicities, and it's harder to manage, and it's harder and takes a little bit more time and effort to reverse grade 3 cytokine release syndrome. So these are not non-toxic. While they're effective, there are still significant side effects that have to be managed, and these often require inpatient admission for a prolonged period of time for monitoring and management. And while we're trying to transition these to the outpatient setting to be more in line with typical solid tumor therapies, we may not be there yet. It's improving as we're learning how to manage these, but it's going to take some time to get there. What was really impressive with AMG 509 was the PSA reduction in a majority of patients. So remember, this isn't first line, this isn't second line. These are patients that are, fourth and fifth line of therapy. And so we can see from the waterfall plots here for the change from baseline PSA, and that's one of our metrics is PSA 50, so a reduction of the PSA level. So, or for those of you not in the prostate cancer space, it's PSA is the tumor marker that we commonly follow. A reduction of 50% or more in that PSA. And we can see there was 2 different doses. It was either 10 or 100 milligrams, and yellow was 100 milligrams and blue was 10. And we can see that a majority of those patients in the upper figure had a PSA 50 reduction, and quite a few of them actually had a PSA 90 reduction, so a 90% reduction in the PSA compared to their baseline. And then the figure on the bottom was also looking at metrics for measurements of metastatic disease as well. And there were changes to that as well. So it wasn't only a biochemical response based on the PSA, but actually a reduction in some of the measurable tumor lesions as well, which is important, that it's not just a biochemical response, but also an imaging response in that case. The other drug that's come out, which interestingly also was developed by Amgen, so I think I'm starting to wonder if Amgen has somehow figured out the CD3 engager portion of this, because they now have 2 potentials that have done quite well. But tarlatamab, a CD3 DLL3, which was awaiting FDA review right now and hopefully a decision in June, had really impressive results. I'm not going to belabor a lot of the results, but this is the swimmer plot looking at 10 and 100 milligrams of this dose as well. And the big point to see across both of these treatments is that quite a few people, even 60 weeks, so almost a year after starting therapy for small cell lung cancer, which is extremely aggressive, remained on therapy. So all of those black arrows are patients that remained on therapy at the time, or were having ongoing treatment. There were a few patients, more than a few, that had disease progression and a few that passed away, but we see relatively few of those compared to the number of patients that are getting a prolonged response and prolonged tolerance to tarlatamab. So like I said, that's under FDA review. There's a thought that this might have a decision towards June, and then this would be the first immune engager approved for use in solid tumors. So there's a proof of concept now, or more beyond even a proof of concept, that we can use these and apply these in solid tumors for T cells. The next question is, what can we use natural killer cells? We all know that at Minnesota we're interested in NK cells. We have good reason to believe that we to like NK cells and prefer NK cells. So we'll talk a little bit about that. And we'll also, the other question remaining was, do NK cells infiltrate into solid tumors? There was a question about that, and is that going to be efficacious or not? But I think we have some interesting data to support moving forward with solid tumor immune engagers for natural killer cells. So why natural killer cells? This is probably a repeat for a lot of the audience here who are involved in the NK cell work, but features of NK cell therapy, importantly, they don't cause graft versus host reactions. So we can use allogeneic or off-the-shelf products. We don't have to use autologous products. You don't have to engineer these to remove or silence the T cell receptor. And that means they're immediately available for use. So somebody comes in theoretically on a Monday and needs treatment. By Tuesday, you can thaw the bag and administer it. That's all theoretically, but possible because there's not the need to engineer the product. There's minimal cytokine release syndrome and minimal neurotoxicity release. So compared to AMG 509 that had 60+% of patients that had grade 1, grade 2, or grade 3 cytokine release syndrome, it's been relatively minimal. There are not nearly the number of studies or the number of patients treated with NK cells, but we're hopeful that NK cells continue that trend. NK cells, while they're not antigen specific themselves, can be made antigen specific with monoclonal antibodies, engagers, or chimeric antigen receptors. But the problem so far has been that they've been challenging to genetically engineer. Hopefully, we're overcoming some of those hurdles. There have been a lot of advances lately, and in particularly, even within our group, there has been some really interesting developments with that. So hopefully, that's less of a barrier than it had been in the past. Related to T cells are a whole lot easier to engineer. They're easier to culture. We already have FDA-approved products, so there's a lot more experience, there's a lot more familiarity with a T-cell therapy. The problem is with chimeric antigen receptors, they take 6 weeks to engineer, and there's a risk for manufacturing failures. It's not uncommon to have a manufacturing failure for somebody who is dependent on a therapy and then needs to continue to bridge or progresses to the point that they can't be treated. And there's a high incidence of cytokine release syndrome and neurotoxicity, which aren't trivial to manage and require inpatient admission. So I'll talk next about applying immune deconvolution to a large data set. So at the University of Minnesota, we are part of the CARES Precision Oncology Alliance. And so what that is when we submit our patient tumor samples for somatic or tumor sequencing, we get whole genome and whole transcriptome sequencing done. So the entire genome and then all of the RNA is sequenced as well with that. This comes back in a clinical grade report for us that points out targetable mutations, but as part of that process, all of that data is saved and then can be used for large group investigations like this. It's all de-identified, so we don't have individual patient data, but we can use this in aggregate. So this was, again, part of a project with the CARES Precision Oncology Alliance there. And what we were able to do is we were able to take over 3,300 prostate cancer patients and analyze their RNA, and then work backwards from this and using RNA signatures determine an estimate of the number of natural killer cells that have infiltrated into a large number of solid tumors. There was actually 45 total groups that we looked at through this process, but really we're just going to focus on the prostate cancer data here. So overall, taking a look at these 45 types here, we have prostate cancer highlighted in red, and approximately 5% of all of the nucleated cells in prostate cancer were attributed to be NK cells. So this was immune deconvolution. It's not perfect. We have struggled in general as a field in looking at NK cells in the tumor using immunohistochemistry and other techniques. So this is another way to apply it. It's not perfect, although it had been validated against single-cell RNA sequencing and flow cytometry as well, and had a very high correlation overall. So we can see some of these groups had smaller or fewer NK cells infiltrating, particularly lymphomas. DLBCL was a little bit on the lower side, 3%, but overall NK cell infiltration was present across a broad number of solid tumors. So it's showing that NK cells are present in these solid tumors, even those that are deemed to be immunologically cold, such as prostate cancer and pancreatic cancer as well. When we take a little bit deeper dive into NK cell or into prostate cancer itself, we took a look and saw how many NK cells are estimated to be infiltrating into the primary prostate lesion, which is the most common, or one of the most common biopsy sites for prostate cancer, but also in metastatic lesions as well. We saw that in the primary prostate, it was a little over 4% for the median, and then slightly lower in bulk metastatic cases. So this was any site other than prostate. And as we can see, again, this is broken down by individual groups within the metastases as well. So prostate was highest, and then bone metastases were the lowest, but it was still a reasonable number of NK cells. It was, I believe, about a median of 3% of the total nucleated cells in even bone metastases were attributed to being natural killer cells. So the other important point, and this has been shown by other groups as well, but natural killer cell presence in the tumor there is a positive prognostic indicator. So more natural killer cells that are present in the biopsy, patients tend to have better overall survival. And the data that we generated with the Precision Oncology Alliance, with the 3,300 samples that we tested for prostate cancer, showed this as well. So The hazard ratio was about 0.6 with very tight confidence intervals, as we can see from the red. But overall, 38 of these 45 tumor types had a positive influence on overall survival if they were at 50% or higher or above the median for natural killer cell infiltration. And then when we see it broken down by prostate cancer as well, for upper above the median in blue and below the median in red, we see that that was statistically significant as well. So supporting the role for natural killer cell therapies, not only showing that they're infiltrating into prostate cancer tumors in a variety of sites, but also there is a good side effect or good survival effects from the presence of natural killer cells. So we broke this down a little further to take a look at the chemokines relative to biopsy site here as well. And this is all very descriptive. We don't have any other correlative data. So this was really fishing in a lot of ways, but trying to use a larger data set to see what else can we do, what else can we look at, how can we potentially improve other therapies moving forward. We're looking at cytokines here. And what we saw in the NK high groups for primary prostate samples, that CXCL1, CCL19, and CXCL3 and CCL5 were all increased in the primary prostate tumors, and similar overall. However, these were not statistically significant for the metastatic biopsy site. The important thing that I forgot to mention here is that just because a primary prostate was biopsied doesn't mean that there wasn't metastatic disease present at the time of biopsy. So that's one of the caveats that goes with our data. It's not necessarily related to the staging. It's often related to the accessibility of the site. A prostate is typically easier to biopsy than a metastatic bone lesion in a vertebra or particularly a rib, which is often does not lead to good biopsy results. So then finally, taking a look from this data set here, there was increased natural killer cells in a tumor, there was also an increased number of anti-inflammatory cells, so almost a counter-regulatory mechanism to compensate for the increased inflammation. So taking a look at the figure on the left here, we're looking at primary prostate samples and versus in the left two columns, and then metastatic samples on the right two columns. So NK low was the bottom quartile, NK high was the upper quartile. So we're changing from above the median to quartiles now for these groups. We saw that if there were the upper quartile of NK cell infiltration, so in the red portion of the bars, there was also increased numbers of M2 macrophages, B cells, and regulatory T cells as well inside these tumors. So again, this is all descriptive. Not anything else to really take more into. It appears to point towards a counter-inflammatory mechanism to compensate for increased inflammation with these cells. And when we take a look at the percentage of these cells here, so there's around 5 or above 5% in the NK high infiltrates. So when we compare that to the number of T cells infiltrating, the number of T cells was only around 1% of the total nucleated cells. So interesting to see that there's actually potentially more NK cells than T cells in there. That's potentially a controversial comment, but as I mentioned, the technique with the immune deconvolution had been validated with single-cell RNA-seq from paired biopsies by the authors of the original algorithm, and then also this had been compared with flow cytometry too, and they had very, very high correlates. So we have to take the data for what it is, but it is an interesting finding, at least, that again supports using NK cells for prostate cancer and potentially for other solid tumors. So we'll talk next about B7H3 as an ideal solid tumor target. B7H3 has come up a lot in the past few years. It's been a particularly interesting target, and it's a relative of PD-L1. And we don't know the receptor for B7H3, despite this being discovered about at the same time as the original pictures that I shared at the beginning of our talk. We still don't know what it binds to after a lot of investigations, and that was even in Jim Allison's lab. So if Jim Allison's lab couldn't find it, there's probably it's been a very difficult process to delve into. There's comments that TILT2 or IL-20 receptor alpha might be the receptor for B7H3. However, those have not been confirmed. There's only a single paper for those that no one has been able to validate in the meantime. On the left, you can see the family tree of other immune checkpoint inhibitor molecules or other suppressive molecules. So CTLA4, PD-L1, PD-1, these are all relatively related to each other. And then if you take a look at the actual structure for the B7 family, we can see that these are all very similar. So multiple immune globulin-like domains with various repeats. So HHLA2 and then B7-1, B7-2, PD-L1, PD-L2 in the middle, and then B7H3 has four tandem repeats or duplicates. And there's also a splice variant that only has two IG regions instead of the four that's shown here. So very similar in a lot of ways, but also very different in ways as we're finding, and I'll talk a little. That. So even within our group, this was Xiaolei Shi's paper from Justin Huang's lab. They investigated a large data set looking at B7H3 expression in prostate cancer and then comparing it to normal tissue samples as well. So looking at B7H3 primary and metastatic disease did appear to have higher levels of B7H3 expression. And then we looked at B7H3 expression in the Stand Up to Cancer and the Stand Up to Cancer West Coast data sets compared to normal data. There was significantly higher B7H3. Significantly increased B7H3 expression in both of the cancer groups relative to normal. And what we don't see is there's no difference in PD-L1 expression in the prostate cancer samples compared to normal. There is actually increased PD-L2 in the normal, and then no difference in CTLA4. And then this did not correlate, B7H3 expression did not correlate with PSMA. And that's important because we have PSMA targeting agents now, particularly lutetium-177, PSMA-617, or Pluvicto, which was FDA approved in the last 18 months or so, and it's been used quite a bit. So why do we like B7H3? We've shown that it's highly expressed in tumors, probably not on normal tissues, but there's also a lot of mRNA expression here as well. The important thing is it's expressed at the mRNA levels we can see here from Protein Atlas, and overall there are some normal tissues that do have some expression of B7H3. But what's important is that the B7H3 protein is minimally expressed even within those normal tissues that do express B7H3. So the figure on the left is cell lines demonstrating just prostate cancer, even cell lines express high levels of B7H3. But when you take a look at the immunohistochemistry for pancreas, lung, liver, and other normal tissues, there is no binding of, or to minimal binding of B7H3. But when we take a look at the tumors, we see very distinct binding noted by the brown staining there compared to the controls or even the normal tissues. So we'll move to talking about dual camelid antibody for the antibody trike to target multiple solid tumors and potentially even hematologic malignancies as well. So here's an image of the evolution of our trike system from a single chain variable fragment to a dual camelid antibody. The upper portion here is the original trike that went to phase 1 clinical trial targeting CD33. So it was an SCFV targeting CD16, an IL-15 linker, and a CD33 SCFV. So this is much larger. It was a single molecule, but it was still freely filtered by the glomerulus, had a very short half-life on the order of a few hours at best. That is moved into a second generation with a camelid nanobody, so about half the size of the SCFV. Then that's linked to IL-15 and then an SCFV targeting CD33, so a little bit larger. What we've done for B7H3, and you'll see some of the data making this comparison from the dual SCFV B7H3 trike. That was the original setup, very similar to the CD33 trike, but we've actually jumped a further step ahead and had developed a dual camelid nanobody tri-specific killer engager. So a camelid nanobody targeting CD16 and then a camelid nanobody targeting B7H3. So much smaller, but the important thing about camelid nanobodies is they are much more stable. Even though they are smaller, they also are able to bind to a deeper groove, and they are higher affinity as well. So we think that camelid nanobodies are going to be the way to go moving forward. And as we see, we've talked about the actual structure of the trike, but how does the trike work? The figure on the right shows this. It forms a physical link between the NK cell and the tumor cell. And then the camelid CD16 binds to, or camelid anti-CD16 binds to CD16 on the NK cell. And then IL-15 stimulates the natural killer cell with the cytokine receptor. And then camelid B7H3 or anti-B7H3 targets the tumor itself. So it forms a physical link. And then the important thing is the addition of the IL-15, because unlike T cells, natural killer cells require a cytokine stimulation for proliferation. In T cells, CD3 stimulation is adequate for that, like we see with the bispecifics and with the CAR Ts. So some of the early data from the initial phase 1 using the dual SCFV trike targeting CD16 and CD33. So this was a trial that Erica Warlick ran, and this was presented at ASH in 2020. Overall, the important message is that the background and the concept of the trike appears to be very safe. So the DLT was, or there were minimal DLTs, the maximum tolerated dose was not reached, and there was only rare and I think they termed it transient cytokine release syndrome that did not require any treatment at that point. So overall, very safe despite a significant dose escalation from 5 all the way up to 150 micrograms per kilogram per day. Importantly with this had to be given as a continuous infusion because of the short half-life. And what we know is that in the solid tumor space, inpatient admission is not feasible particularly often. Most of the time, the line that we use is you have to be able to walk into clinic to be able to get chemotherapy, unlike some of the other hematologic malignancies where we know you have to have an inpatient admission and be monitored acute leukemia, some of the lymphoma regimens like that. So most of the standard for solid tumors is really designed around an outpatient administration. So that's what led to some of our other work, as I'll talk about in the trial, of administering subcutaneously rather than a continuous IV infusion. The only other thing to add for the CD33 trike was that there was in the correlative studies, there was a dose-dependent and sustained proliferation of the endogenous NK cells with the dual SCFV trike. So we saw that CD16 was retained even after treatment, but also there was significant proliferation and expansion of NK cells at day 8, 15, and 22 after completion of each of the weeks of the treatment cycle. And there were still NK cells preferentially proliferating compared to CD4 and CD8 T cells. So really, the trike is able to redirect that cytokine signal towards the natural killer cells. So as we move forward with our B7H3 trike, we wanted to evaluate the specificity first of this dual SCFV trike. So taking a look at 2 of our knockout lines that we were able to obtain from Crystal Mackel's lab at Stanford, BT12, our pediatric rhabdoid tumor, so a CNS tumor. We can see that the positive for our control, our commercial control, and for also our binding of our camelid nanobody are clearly positive, while our negative controls are quite negative there. So it's a very nice, clean signal. We saw that also with the knockout as well in the middle column. So these were B7H3 knockouts on this same line. Overall, a very clean signal showing the specificity. And then we see that a prostate cancer cell line D145 had very high expression of B7H3 as well. Importantly, not only was the trike able to distinguish for phenotyping, but it actually made a difference in NK cell functional assays. So looking at NK cell degranulation and inflammatory cytokine production using these same cell lines here. So highlighted and these assays involve, in these assays, you take target cells and incubate them for 5 hours with natural killer cells and trike or IL-15 alone or other control conditions. And then we run by flow cytometry and look at CD107A, which is a marker of degranulation or interferon gamma production. And we see that these were statistically significant, as highlighted in the box. The upper box, or the figure on each of the left, is the B7H3 intact wild type cells, while the knockouts had very minimal increase in degranulation or cytokine production compared to the control arms without treatment of trike. So that was important too. Not only was this able to differentiate in terms of phenotyping, but in terms of function. We also took a look and wanted to compare the B7H3 trike for the dual CAM versus the dual SCFV. And what we see here highlighted by the blue arrows is that in fact, the dual CAM appears to be more potent in terms of degranulation for CD107A. The dark gray box with the blue arrow there compared to controls had significantly higher CD107A production, but also there was increased proliferation of NK cells treated with the dual CAM versus the dual SCFV. Which is good. And again, it's a great thing to see this, and also important as we move forward. But we can see even across a range of nearly 100-fold differences in dosing from 30 nanomolar down to 0.3 nanomolar, we do see a difference, and there is a dose-dependent effect on proliferation. So we can see in the upper portion here, or the upper two that were treated with 30 nanomolar, we see that the curves or the peaks are shifted to the left, meaning that there's dye dilution. So this is a proliferation assay. So with each subsequent proliferation, the dye is diluted. So the further left, the lower intensity of the signal actually means that that cell had proliferated more times. And then we can see in red here that these were the unproliferated cells further to the right. So we had talked about redirecting IL-15 towards the NK cell specifically by targeting CD16. T cells don't have CD16 on them. And so the thought is that by using CD16 to directly target IL-15 to the NK cells, we could minimize the effects of IL-15 on T cells. IL-15 can also stimulate T cells and particularly expand regulatory T cells as well. So this is taking a look at those same proliferation assays, but just focusing only on the dual CAM now. And what we see is that the number of unproliferated T cells is approximately 70%, and the number of unproliferated NK cells is nearly zero. But when we take a look at the total proliferated T cells, maybe 10, 15%, but nearly 100% of the NK cells had proliferated. So this delivers a specific cytokine signal to the NK cells, which is important to the side effects of the product as well. So as we move forward, we showed initially that there was degranulation, or there was B7H3 expressed on our non-hormone resistant prostate lines, but we also wanted to see would our camelid B7H3 trike also elicit a response to degranulation to other known androgen receptor targeting therapy resistant lines. So we repeated our functional assay using CREB5 mutated cell line or LNCAPs from Justin Huang's lab, and then 22 RV1s, and then additionally enzalutamide resistant LNCAPs as well from Justin's lab. And we had a pretty wide range of donor response here, as we can see by the broad curve, but overall the trike was able to induce degranulation in all of these cell lines as well. The variability in response is a whole nother question that we're trying to delve into to determine why some normal donors have really good response with the trike and other donors have very minimal response. But overall, we've repeated this several other times and seen very robust responses in general to the trike against a number of solid tumor cell lines, not only prostate cancer cell lines or even hormone-resistant prostate cancer cell lines. So next, the question was, we tried this in cell lines, but what happens in patient-derived xenografts, trying to move forward and trying to go with a more realistic model. And this was data that Gwen, one of our grad students, and then the other technicians in our lab had generated from patient-derived xenografts from Eva Corey's lab at the University of Washington in Seattle. And with this, what we saw was the 35 CR, so a castration-resistant line, had similar induction of CD107A compared to B7H3 trike or a bispecific killer engager. So highlighted, we can see for the 35 CRs here in purple. So B7H3, very highly expressed and led to significant degranulation with our bispecific, but also, or our trispecific, but also our bispecific also, and then compared to C4-2 prostate cancer cells, which were our control line. And we ended up choosing this control because it had both PSMA expression and B7H3, while the 35 CRs did not have PSMA expression, but had B7H3. So we saw that this was relatively clean expression overall with that, and then very similar with interferon gamma production as well. So again, reassuring as we move this forward, trying different models, trying to get more realistic or more closer to treatment in patients. From what we see, the trike does appear to work in vitro. So we wanted to take a look at trike killing as well, taking a look at the cell lines here. This is an IncuCyte, so it's a 2D assay using labeled cells. Cells are labeled with nuclite red, so we can see this actually on the figure on the right. When the cells are alive, they produce the red reporter, which can be detected. And then this is scanned every hour, and cells can be quantified. The figure on the left is looking at PC3s only, so this is another prostate cancer cell line, and cells alone continued to grow. When you added NK cells in green, there was only minimal killing of the NK cells. So, and then when you added IL-15, there was a little bit more killing. And finally, the trispecific in purple had nearly complete eradication of the target cells after 4 days. The bispecific in orange, interestingly, had about the same amount of killing for about 24 hours, but the lack of cytokine stimulation that trailed off, and eventually that effect was lost, and there was a rebound in the tumor growth. And that's fitting with what we would expect. So the next thing, one of the things we've struggled with is in vivo models for prostate cancer. So the other groups and grad students here, so this was Avine's group, one of the grad students in our lab had shown that this worked quite well in ovarian cancer models. So tumor alone versus B7H3 trike treatment, there was a significant response to the tumor suppression in this figure here, so showing the proof that not only the B7H3 trike can work in vivo. We've tried quite a few different models for prostate cancer, and we have yet to hit on or find one that's quite worked yet. But it was important to move forward because B7H3 was such a great target. Multiple other investigators in the lab have been looking at B7H3 to target solid tumors as well. And so this was one of the first experiments that worked very nicely. And so again, supporting the use of this further in for solid tumors. One of the other questions was dosing strategy. As I mentioned, we're trying to move forward to a subcutaneous dosing from a continuous IV. Continuous IV is hard to administer when you're attached to an IV pump for 5 days. So taking a look at the CD33 trike, this was mainly taking a look and seeing, can we dose reduce or administer in a different fashion and have similar efficacy? And this was looking at CD33 expressing HL60 tumors, but when you have tumor alone, those grew quite quickly. When you added NKs, there was a little bit better control. But when you look at trike intraperitoneally 5 times a day versus IV once a week versus subcutaneously once a week, overall those growth curves were relatively similar. So showing that maybe we don't need to administer continuously for 5 days in a row, and that subcutaneous might be a possibility moving forward. This was a different trike, different targets, but at least moving forward to that concept that we could potentially transition the B7H3 trike to a subcutaneous administration. And then finally, getting into our last few slides here, we wanted to take a look at actual prostate cancer patient immune cells themselves, or NK cells themselves. And so these were samples from our genitourinary biobank that had been previously collected. Overall, this is a table showing what we have there. The important thing with this is this is a very Caucasian-centric biobank. So 14 of the 15 samples that we collected were white males. So it does a good job of showing proof of concept, but also, as I'll mention, one of the goals is to try to expand the diversity of the biobank, because We know that particularly in prostate cancer, there can be ethnic differences in the immune response, particularly with sipuleucel T, which I had highlighted initially. There are significant differences within groups. But this was our group taking a look at the breakdown. Overall, there was a very heterogeneous population in terms of treatment history too, so it makes it hard to find a clear response signal. But the important part of this was that degranulation was preserved across the board, whether between normal donors, between hormone-sensitive patients, or hormone-resistant. So really highlighting the two figures on the right here. Degranulation in the hormone-sensitive was approximately 80%, and also about 80% for the hormone-resistant patients. So the trike is able to induce good degranulation even in the hormone-resistant patients that have been highly treated. And that appears to be very consistent as well. And we see a stronger, overall, a very similar effect for interferon gamma production as well. So that this is really the final step for preclinical anyway, showing that this not only can target prostate cancer in cell lines, it can target prostate cancer from patient-derived xenografts, but it can also rescue or at least maintain patient effector function as well, which is important to see. The only major thing that we really saw was a proliferation defect with the trike in the hormone-resistant samples. So, a function seemed to be very similar, but proliferation did seem to be markedly reduced. So really focusing on the figure on the right here, normal donors were light gray, castration sensitive were that medium gray, and then the dark gray really had their curve shifted to the right here. So there was less proliferation in these castration sensitive patients, which we don't have a good reason for why that is at the moment. The last set of experiments that we did for this was to take a look at the patient samples that we had collected by CyTOF. So here are the two panels that Martine and the TTL have developed, looking at a broad number of NK cell markers, but also a comprehensive immune panel as well. And taking a look at that, there was not really a lot of differences. We were a little surprised to see the only difference that stood out, and it was only a trend, was that NKG2A was higher in the hormone-resistant patients compared to the hormone-sensitive patients. PD-L1 expression was the same across the groups. TIGIT expression was the same. LAG3 was the same. And this P was 0.06. So as I mentioned, this was a very heterogeneous group of patient samples, very broad spectrum of prior treatment histories. So we're hoping that as we get a more homogeneous patient population in terms of treatment history, that we might be able to pull out a little bit more of a signal. So right now we're focusing on collecting patients that are a much more consistent spectrum of patients from clinics. So this leads to the final part here for the phase 1/2 trial that is under development right now. So the goal is to conduct a phase 1/2 clinical trial to investigate the safety and efficacy of our CAM-B7H3 trike for not only metastatic castration-resistant prostate cancer patients who have progressed on a single androgen targeting therapy, but also for standard of care refractory head and neck squamous cell carcinomas, non-small cell lung cancer, breast and ovarian cancer patients as well. And the prostate cancer arm of this is in development with the Mayo Clinic as part of a joint prostate cancer spore application that will be submitted at the end of May. So this is just a very high-level overview of the trial design. And as I mentioned, we're trying to transition this to subcutaneous administration from continuous IV administration. So the drug right now is planned to be administered 5 times a week, so Monday through Friday subcutaneously. So rather than being hooked up to a pump, the patient gets an injection once a day. We may have to change this dosing, but that's the goal right now, is to try 5 days a week with the weekend off, and we would treat for 2 weeks in a row, followed by a 2-week rest period. And then we'll also collect a number of correlative samples to look at blood counts, flow cytometry, looking at NK cell expansion, and then also for CyTOF as well, looking at changes in NK markers and other immune markers, and then immunohistochemistry for tumor infiltration. We talked about the correlative studies here, and then just very briefly, some future directions. Looks like we're just about at the end of our time here. So I'll briefly talk about the interest in looking at androgen receptor targeting or blocking of androgen receptor. As I mentioned before, at the very beginning of the talk, the backbone of treating prostate cancer involves blocking testosterone. Normally, this works very well in the hormone sensitive setting, but eventually all patients, given enough time, will become hormone resistant. What we don't know is the effects of blocking testosterone on natural killer cells. So we were thinking about this when we had our KLK2 CAR T from Janssen, and we were treating prostate cancer patients. And the requirement on this study was to have a castrate level of testosterone. All of our other CAR products that are commercially approved for myeloma, for lymphoma, for ALL, all do not have any hormone requirements. So this is very, very different than any of the other products that have been tested before. So we thought it was an interesting question. We've started some preliminary work into this. But interestingly, the group at Oregon Health Sciences and University of Washington actually took a look at T cell function and found that T cell function in the context of not only androgen deprivation, but actually blocking the androgen receptor itself with enzalutamide as well, and then pairing it with an anti-PD-L1 antibody pembrolizumab, there was an increase in granzyme B and TNF alpha production as well. So there's something there, at least in the T cell space. Interestingly, so that the senior author on that was Amy Moran, who did her PhD at the University of Minnesota. And I was talking with her, I think a year ago now at Prostate Cancer Foundation, and she said she wanted nothing to do with the NK portion of this. So it's interesting, but it's also a good opening too, that they didn't want to be looking at NK cells. But I think it's important too, as we're developing these, we're making an assumption that everything is the same, whether hormone intact or not hormone intact. And here's just some very preliminary data here looking at enzalutamide blockade. It's not statistically significant. We were still getting the experiment set up, but taking a look at NK cell degranulation in the presence of D145 cells with trike, and then either no treatment in blue with enzalutamide at 2 microliters or enzalutamide at half that dose, or just vehicle alone. And it does appear, at least preliminarily, again, this is just a trend based on a small number of samples, but degranulation did seem to increase in the presence of enzalutamide. So some future directions, we clearly need to have better understanding of the mechanism and the dosing strategy on NK cell function. We will learn a lot of this through the trials and other correlatives and all of the other projects that are moving forward. This is only really a small slice of everything that's being done with trikes, let alone the B7H3 trike. This has been a lot of work from many, many people in the Miller and Felice's lab. We're working on developing NK cell secreted engagers and CARs also. So that's the next step to move forward. Those are in process. As I mentioned, expanding the diversity of the GU Biobank in terms of ethnic background, but also in terms of trying to consolidate a little more in terms of treatment to really delve into the signals and changes in immune markers. And then applying the lessons from our other phase 1 clinical trials at the University of Minnesota as we're moving into the solid tumor space. We've had multiple prostate cancer eligible immune engagers targeting B7H3, targeting PSMA also. So we're learning a lot in terms of clinical management and patient selection for this as well. So in conclusion, solid tumor therapy has radically evolved since 1999. As we saw with that, we've really gone away from autologous stem cell transplant. Auto transplant is really only standard in rare exceptions. And as I mentioned, really germ cell tumors, testicular cancers are the only indication that we even remotely commonly see in adults at this point. There are quite a few bispecific T cell engagers or BiTEs in the pipeline that are potentially in line for approval in the very near future. So that's really practice changing in the solid tumor space. We're finally catching up to the heme malignancy space. B7H3 is a promising target, and NK cells do appear to be infiltrating solid tumors. So giving us proof of concept that NK cells and B7H3 or targeting B7H3 with NK cells may be a good way forward. We're developing our camelid B7H3 trike for a phase 1 trial here at the University of Minnesota, and we still have a lot to learn. We're only starting to delve into this. There's a lot more to go, but it'll be really interesting to see, and it's been really fun to be in this part, not in the lab and the clinical side with all these changes coming up. So thank you to everyone in the lab, too many people, and I've probably missed some of the people that have moved on and gone to graduate school or otherwise, but I couldn't have done any of this without everybody there helping me throughout the way with that. And my funding sources, Prostate Cancer Foundation Young Investigator Award, Department of Defense Early Investigator Award, and then the clinical trial was developed with, I was able to attend the American Society for Transplant and Cellular Therapies clinical research training course 2 summers ago. And that was really instrumental in helping design the trial, or at least the initial backbone of the trial. So thanks, I'm happy to take questions.
right, I have microphones for anyone that has questions.
Nick, that was great. Although I did come here in 1999 when you were still in high school, and had a very interesting conversation with Phil McGlave and Linda Burns at the time about high dose chemotherapy and autologous transplant for breast cancer. And they kind of said, "Well, do you want to keep doing, or how do you want to be involved?" And I said, "Well, it's a hypothesis testing experiment, but I don't think it's going to work," which ultimately didn't. But at least it was an interesting thing to participate in at that time. Just my editorial comment is, though, I actually think that particular example set breast cancer therapy back, because big pharma said, well, if all you got to do is give high dose chemotherapy, why do we need to make antibody drug conjugates or immunotherapy? So at any rate, that's my editorial comment. My question for you, if half-life is a problem, what's the advantage of having a camelid CD16 as opposed to using just the FC domain of an antibody and making a bispecific antibody instead of a trike?
So yeah, that's a good question. There are different properties to the actual antigen binding itself. They tend to be higher affinity. There's also the thought that the camelid antibodies are more tolerant of the extreme environment in the tumor, so the lower pH, and they can bind into a smaller antigen pocket. The other thought that's in process has really been developed is the trike pack that Martine has developed by adding either human serum albumin that binds to the IL-15 by an IL-15 receptor alpha HSA component that binds and forms what's thought to be almost a near covalent interaction. So that doesn't impair the trike, it seems like, but it increases the molecular weight and then should increase the half-life. So there's that thought, while gaining the benefits of having a camelid, also being able to increase the half-life.
And you brought up in the beginning the idea of T-cell engagement. So have you or other people just swapped those domains around, the CD3, CD16 questions, or you showed an antibody very early on in the beginning that basically took out the FC function? It looked like it sort of.
Oh, yes,
Yeah.
yes.
So anyway,
509, yeah.
have people done preclinical work to say, well, T cells are better or worse than NK cells with the same molecule?
I don't think we've done the exact comparison of T versus NK, at least in our lab. I don't know about others, whether they have just traded out the engager to see, head to head or not. There's also a thought of, would you need a cocktail in the future of some NK and stimulation and redirection, and also T cell redirection, knowing that none of this happens in isolation. So there's that thought, but I don't believe anybody's done it head to head.
So Nick, this is the most ideal target antigen. When you think about, it's so interesting that, here you have this mRNA expression in nearly every tissue, and yet you have no protein expression. And so that's a question by itself, like, why is that occurring? And is there any other example? But we'll go to that later. But what's happening in industry? You would think that every industry would be trying to get this target because it's expressed so broadly. So where are we at with, whether it be, other bikes or trikes from industry, or whether it be, CAR T cells? And there are some studies being done now. And I guess the question is, have you seen any preliminary results coming out?
So there's just a monoclonal antibody called enoblatuzumab that's being developed by Macrogenics. We had one of I think it was a phase 2 trial for treatment of metastatic prostate cancer. There's also antibody drug conjugates. I believe there's several of those. Macrogenics had one, also Daiichi had one as well, targeting B7H3. And then there was previously, Macrogenics had a bispecific that was terminated, the CD3 B7H3 for hepatotoxicity. So what we've run into, even though it appears to be a great target overall for normal tissues, there's this hepatotoxicity signal that we can't seem to get around regardless of the construct. We're seeing very similar effects with the CD3B7, another CD3B7H3 engager. The big question is whether this is cytokine release syndrome or something in the liver.
Toxicities with antibody therapies are pretty common.
They are, and that's part of our question is this related to B7H3 specifically, or is this something else from more of an immune stimulation inflammation side effect? Because these tend to resolve.
Any data that gives you a sign of efficacy?
Not that I've seen yet for the bispecifics anyway. It's all very early. There was, I believe, for the bispecifics anyway, I believe the DS7300 had some preliminary efficacy that was at ASCO last year, but it was only a few patients treated with that. And then in the neoadjuvant setting for prostate cancer, the monoclonal antibody, just the naked monoclonal antibody, actually downgraded tumor grade and size in prostate cancer pre-surgery. So they were treated, and then the resected prostate was actually looked at pathologically and with immunological staining, and there was a significant downgrading in the grade in that. So that was really, really supportive of B7H3 as a target in early stage prostate cancer. So I think that's the best evidence we have so far.
Nick, that was really cool. I want to follow on Doug's question, maybe a little bit on John's question as well. So I was talking to Pam Contag last week at AACR, and her company is using a really interesting approach, using NKT cells as delivery vehicles for a thing. But one of the things she told me is that she likes NKT cells because it seems that the cells actually have this plasticity to actually fully differentiate to either T or NK, depending on the environment that they find themselves in, to be most favorable. So I wonder if you guys had thought about looking at these patients, or even in the xenograft experiments, at the infused cells as they go in, and then when they come out, and looking at the proportion of T cells, NK cells, and NKT cells, and seeing whether whether the trike is inducing any distinct lineage maturation in addition to the native NK cells expanding and the T cells not, whether any of the expanded NK cell is a contribution from NKT cells creating that pool. Because one of the things that seems to be happening is that those cells have massive proliferation potential compared to mature NK cells. So I wonder if NKTs are, if you have any to begin with in these models, and if they're creating the pool that you're measuring that expansion.
So I think it's really interesting to look at the other NKTs or even gamma delta T cells. There's some efforts trying to take a look and see whether the trike could work with gamma deltas. I don't know about NKTs themselves. The phenotyping is a lot harder. It's more than just CD56 positive, CD3 positive. I don't know if our panel can actually distinguish true NKT cells or not based on that CyTOF panel. And Martin is shaking his head no. So I think it's interesting. I don't know. We don't have it developed to actually look at that, but that would be an interesting question.
Take one more question.
So in your cartoon, the end result is the NK cell engaged with the tumor cell via the trike. How does it get there? Is it the trike engages with the NK cell and enhances its homing to the tumor? Does the trike bind a tumor cell and enhance the likelihood that it'll snag an NK cell? Does it matter? And if it does, can you tune your system so that you can preferentially have one happen over the other?
I don't think we know at this point what is going on to bring all of them together. We've tried preloading the NK cell 2 before injection with the trike to try to take or reduce the number of random events that have to happen, or at least what seems to be random. So the NK cells are injected with the trike already on board, and then all they have to do is find the tumor. To my knowledge, I don't know if we actually know what it is. I think it's random right now. Potentially, if there's something involving a chemokine, delving into some of that KRAS data to see if we find a signal that is there something we could add or change to a trike, or to drive NK cells towards a tumor if we know that those tumors are already producing a chemokine. That could be interesting to pursue, but I don't think we have a good answer right now.
Thank you. Let's give Dr. Zorko one last round of applause.